Okay, we started the recording. Well, good evening, everyone, and thank you again to our weekly town halls. And we're proud tonight to have Starlyn back to teach us again on another COVID topic. And this time she's going to be focusing on diabetes and its relation with COVID-19. And I'm going to go ahead and ask Starlyn to go ahead and jump into her presentation, and we'll go right to it.
Is it happening? Oh, are we there?
I can hear you.
I know, but I'm not in the thing. I've got to do the Alt Tab thing again. All right, let's try it one more time. It like skipped. All right, here we go. Perfect. There we go. Can everybody hear me?
Yep.
Can everybody see my slide? Okay, just for grins and giggles, because this might show up on a trivia contest or a Jeopardy question in the future. So you see the little prongs that come off of the coronavirus? Do you know why it's called Corona? And it's not because you drink Coronas in Mexico. So Corona means crown. So when they put the illumination media on it to look at it through the microscope, when they see the curve, it looks like the top of the sphere has a crown on from all these illuminating. So a little trivia for you. All right. That might show up on a Jeopardy question, I'm just saying. I don't have anything to disclose. Here are the objectives. We're going to review the emerging evidence and changing evidence with COVID and people with diabetes, and discuss some glycemic control during this process. Our pre-test question is, among COVID-19 cases, which underlying health condition, or plural, are the most at risk to develop severe illness from COVID-19? And you have options A, B, C, or D. Okay, so when we're talking about, it's been in the news, if you're over 65 or older, if you're in the nursing home or long-term care facility, you're at greater risk. Why are you at greater risk? I would like to amend this long-term care facility. Any group living situation where you're in close proximity and you have multiple ages, and if you have people that are living with you over 65, they are just as at risk as if they were living in a nursing home or long-term care facility. So young people have to remember that grandma and grandpa might be home when they're living in close knit worlds, and a lot of families have come together in this time to help support each other, and so we have multi-age groups. So people of all ages with underlying medical conditions don't do particularly well. Chronic lung disease, even moderate to severe asthma, severe heart conditions, especially congestive heart failure, immunocompromised people, including cancer treatment, and those who, I'm adding the rheumatoid arthritis people that are on any sort of immunosuppressant. They are finding persons that are taking HIV medications, actually, because we're using some HIV antivirals as some of the rescue agents for decreasing inflammation. So there's some studies out there. So there's news to come out about that still yet. They've been talking about it, but haven't seen any really well evidenced studies. People with diabetes, people with high body mass, so severe obesity or morbidly obese. And again, we talked about the chronic lung disease, and then people with liver. So it's all about how well you're managed. So you could be a 65-year-old fit person that's doing very well, and maybe the only reason that you have high risk is that you might have an underlying asthma condition that still puts you at risk. But if you're healthy, and like Dr. Fossey, he's not exposing himself. He's 79 years old and he's doing well and he's fit, but he's still not exposing himself. So he's taking good care of himself by wearing a mask and avoiding close connections. So with people with diabetes, they tilt the stage. What about diabetes that also adds another comorbidity? You say, I say cardiovascular disease. So when you have diabetes, you don't just have one of the risk factors, you have two. And then that of course involves the liver. And then if you're higher in weight, then that all plays into the complications. And so it keeps increasing the risk and increasing your risk of respiratory failure, and then increasing your risk with death. So this just came out this week, and you probably have seen it on the television and on the news, about that people with underlying diseases hospitalizations were 6 times higher and deaths were 12 times higher. What's important to note here is that the cardiovascular disease of the people, this is as of May 30th, and this was posted June 15th. 32% of the people hospitalized had cardiovascular underlying disease, 30% had diabetes, and 18% had chronic lung disease. So that I want to emphasize these comorbidities that our patients have, so that they understand that it's really important for them to protect themselves. This next 3 slides is actually one long infographic, and it's kind of hard for you to see, but I wanted you to, you'll get the copy of the slides. Here you can go on to Diabetes Daily and you'll get the whole full infographic. What's important about this information that I'm going to share is it quizzed 20,000 people with diabetes that are members of this newsletter group. 1,300 of them answered. Out of the 20,000 that are members, 48% of them have type 1 and 52% of them have type 2 diabetes. And so more than 50% have reported that besides diabetes, they have another health problem that increases their severity of risk. Most likely, as the picture shows you, the heart. This is here. What is interesting to me is right here is this 3%. So of those 3%, this age demographic is everybody under the age of 35 years old who have diabetes, and they're 100% of them are not worried about coronavirus. So what's important about this is that we have people that are concerned, very, very concerned, somewhat concerned, slightly concerned, no concern. And so likely the 35-year-olds and under are persons who probably have type 1 diabetes, and they are just at the same risk for cardiovascular events when they're infected with COVID-19. So this is the middle part of the infographic. They asked them how were they prepared, or what were they most afraid of. 50% were afraid of food. 100% were afraid of losing toilet paper and not being able to obtain it. 52% were afraid of something else, be it of shortage. Only 58 were afraid of medicines, and 72 all were afraid of becoming ill. So what this is saying, what I'm trying to show you, is that your patients have a concern and will need our help as pharmacists, because we've been running toward the fire. So only 34% obtained extra medications, and maybe because they were somewhat confused by the evil gremlin PBMs not allowing certain things right off the bat, and now they think COVID's over, so they're not allowing the fact that people with these chronic illnesses probably are not going to physically come into doctors' offices and pharmacies, And so they are still holding up and lagging behind on some of the ability for some of these patients to get their medications, or our patients are just confused. This one is about how many people have been are going to be tested or have been tested. 70% of these 1,300 people have not been tested. Only 2% of that group tested positive, 23% tested negative, and 5% were waiting results. So that gives you a pretty good idea of how things were going on in the end of March. Another good point I want to emphasize is that this group of people with diabetes are not remote workers. They're not working remotely. Probably most of them are, about half of them are probably retired, and they're not so they're not leaving home because they're afraid, and all of them are social distancing. But some of the other people with diabetes that are working in jobs that don't allow them to work remotely. So they're service centered, or they're in the healthcare industry, or they're medical assistants, or they work in a system that can't be put into remote work environment. So that increases their risk of exposure because they can't work from home. So you can get a full copy of this. The link's in there. I just thought you'd like to see what was happening with a survey of our patients. So the number one thing that we all need to do, and you've heard this 100 times, is to prevent the infection. It's really important that instead of just using hand sanitizer, that they try to wash their hands with soap and water. If you attend our certificate training program, you find out washing your hands with soap and water rubs the hands, gets it going, so it's probably easier to get a finger stick. The other thing is that if sometimes people are in a hurry and if they use the hand sanitizer, the alcohol is still wet on there, and that will cause inaccurate readings on your blood drop. And but most important, it's reinforcing our 20-second hand washing ability. So we're reinforcing that, because over the years I think we've gotten sloppy, and I've seen people not even wash their hands and just test their blood sugar. Staying at home and avoiding crowds, 6 feet apart, wearing a mask cover. It's interesting, I was on the phone with United Airlines today, and I ended up in a 20-minute conversation with one of the clerks trying to help me sort out my tickets to get refunds. And I explained all this to him, and he was grateful, because toward the end, he actually is a type 2 person with diabetes, and he hadn't realized even that it was more important for them to do this to help protect themselves, because they were more at risk. And he was only 50 years old. So thanks to my editor, Dr. Roselli, she reminded me that we need to make sure that our diabetes language is positive. So we changed the glycemic control to management, especially during COVID, and all sick areas. So right now we're gonna review the ability to keep track of your patient's blood sugars, and of course, blood pressure control, because those are also important. And that's something that pharmacists are very well qualified to do. Geez, you telling me I'm not gonna get through all this. You're right, Garth, I stand corrected. So high blood sugar can happen when the body reacts to any illness. And so that happens when you have diabetes and when you don't have diabetes. So even patients that are post-op a very long surgery, they have to watch the sugars and the hormones, because they're trying to repair their body or fight the illness, and so you release the stress hormones, which makes your insulin less sensitive. So in COVID, that's even more, because of the processes of that virus. Even with common cold and flu, you know that we prepare people for their flu processes. Again, we need to remind people that during this COVID, if they can come out, they still need to get their flu vaccine the end of September or mostly in October so they can have that long track. Also, I'm sure you've had an elderly person that's had a urinary tract infection, chest infection, or skin infection and seen their blood sugars change. So those are things that they have to keep monitoring. So during these issues and during any time we have, like if you're in a hurricane or there's fire outages or any sort of disaster plan, our emergency cases we need to have in place. We need to have those refills before they're due of the prescriptions. I'm not telling you, I'm speaking to the choir, but it's important that we inform our patients about this because we're getting lost in our days. So having those gentle reminders or a telephone call helps their social isolation and helps remind them that they can get their 30-day supplies of their insulins and their other diabetes meds and all their chronic disease medications, and that you, the great pharmacist, will help them ride out the PBM that's stalling the process, and that you have the ability to do that. If they're visiting the pharmacy, let them know that you have a curbside option or a delivery window. Right now, I'm getting lots of emails from the PBM that's part of my insurance wanting me to convert everything to mail order. I won't do it. So we as pharmacists could offer that mail option for people that really don't want to get in a car and drive in if they're that far out. There are challenges in some of them hitting the donut holes early because they're getting these early refills. So NovaCare and Insulin Affordability and Sanofi all have a website that can help our patients try to leverage that. Okay, so sick day diabetes supplies includes if they have a CGM. If you have a CGM, you need not just the CGM, you need all the monitors and the sensors and all the supplies. And if you're using your phone, you need to make sure you have your ability to charge your phone. For the same for your glucose meters, you need to have ketone testing supplies because during sick days, the ketone, we need to be measuring the ketones. There's two things that the doctor's going to ask when they call in about if they have flu or COVID symptoms. What was their blood sugars and what were their ketones? They need to have, so the other thing are the highs and lows that when people are sick. So people will go really high and get hyperglycemic, and they'll go really, really low and get hypoglycemic. So they need to make sure they have glucose tabs and juice and hard candies on stock for that. And always, always, always have plenty of water and sugar-free beverages because dehydration is the #1 thing that kicks everybody out. So when you're dehydrated, then your regular medications have to be altered because you don't have enough volume of distribution in your body to manage these new classes of drugs that are out. It would be great to everybody have a emergency glucagon kit, but you guys know how expensive that is. So if you can get them, we want to try to get them for them. In this period of time, I've seen the prior approval process is faster on getting these glucagon kits. So if you have patients that can qualify, I'd get them now. Then they'll have them for after the COVID. So you always also have to have a technology backup plan because if the pump or the CGM or something is not working, you've got to resort back to having a good supply of your backup plans, extra pin needles, insulin syringes for everything, because if the pump or the pod stops working, you go back to shots. And then the CGM, you always have to have a blood glucose meter and testing supplies on the backup. Telemedicine appointments, these are being paid for by Medicare. You can work with your local doctors and you could be part of the remote monitoring process and help them and get incident to physician payment. But just for good service to our patients, the PSMP program, we're using all of these. We're letting the patients pick their platform because they've lightened the load on our HIPAA requirements on it being encrypted. So Doximity is really a good free program that allows you to use your smartphone. You can see people. You can program in your pharmacy number, and then it shows that number, not your home number. So it's a great thing that they've used. I'm sure I've been using it. Well, we've been using it PSNP for the past 3 years, and we were using the free version, but we'll see what happens as we go forward. Okay, I'm getting close to the end. And then the blood sugar data, if you have one of the One Touches or Abbott's, you can share that data remotely so that you can help them out with their blood sugars. So one thing that is very, very important is never, if they're on insulin, never stop taking their insulin. So we know people have been kind of not being able to afford their insulin, so they've been giving themselves less and stretching that out. But it's important that we do that, and if they cannot afford the insulin, that we try to tap into those pharma companies that have that system set up for them. And right now, it doesn't matter if they're government subsidized or not. Everybody are able to access those pharma insulin provision companies. It's like I told you, the number one thing is the dehydration. And so staying hydrated is one of the most things to help control the blood sugars and the ketones, so that your underlying diseases and symptoms can be taken care of at that level. I can't see all these. So these are things to remember. Like I said, you can take this slide and print it out and use it as a handout for your patients to remember what they need to be doing when they're checking all their numbers and checking their symptoms for diabetes. I say diabetes ketoacidosis because we're supposed to stop the ick, and when to call the doctor, and we have people that are not showing up in the emergency room because of COVID, and we have people not doing very well. So many of our people with diabetes are relying on us to be a source to encourage them when they're in the bad, either super high or super lows, that we help them get contained, and then they're seen by their doctor. This is for hypo. So this is another handout that you could just print out and use for patient education. I'm talking to the chorus here about the cold medications. It's important. Sometimes we don't get to talk to them when they're in the front end, but if they're taking syrups because they have a cough and decongestants that have sugar and alcohol, they're better off with taking pill forms. Also, in the literature is that acetaminophen can cause false readings if they are running a fever. So if someone comes in with cough and all these symptoms of COVID, and they're going to have to take Tylenol. So even if they have a CGM, that'll help them with their highs and lows, but it does give some false readings, so they have to back up with finger sticks. Again, this is the symptoms, and we're including everything that because they have diabetes, if they're having this symptom modality, they need to be in conversation with their health professionals. Sometimes if you're the diabetes educator, they're going to call you first, and then you can help them navigate the process by which they contact their physician. Some things can be handled without them going to the ER, but if they're really, really severe, we need to, they have the tendency to go fast. One very important thing is, because of their diabetes, they are at a higher risk of DKA, and they can go into sepsis and shock faster because of their diabetes. They end up using more insulin. I don't know if you guys follow me on Facebook, the 20-year-old girl that got the lung transplants up in Northwestern, they had her x-rays of her chest, and they had one of her lobes of her lung where they showed how it just got so inflamed and congested that it wasn't soft sponge, it went to a hard sponge. And these are the things that contribute toward that whole process. So while there's the insulin needs and the fact that they're increased for DKA and the treatment of that, we also need to remember the new classes of drugs. On ADA's website, they have some podcasts. They're quick, they're short. Dr. Ann is talking about her moderate and severe patients that are on the SGLT2s and the GLP-1s. She had to back off of them because they were so dehydrated until they got an IV in them that they were having a higher risk of DKA as a result of being on some of these new classes of drugs. So that's important for you to remind people about the hydration. It has to do with the volume and distribution. And so if you don't have as much fluid in your system, your drug concentrates. And so it makes a higher risk for any of the adverse reactions. Gluco is a good program that helps you collect the data so you can virtually work with patients. And I'm telling you right now that COVID moved the use of A1C versus time in range for CGMs up a few notches. So we're gonna start seeing more people with CGMs. And so if you're not carrying the Abbott Libre, it might be something you should be interested in. Okay, here's the post question. So as you know from all the slides and the 5 million times I said it, cardiovascular, diabetes, and chronic disease are all underlying health conditions that pose the most risk to develop severe illness. In the slide sets, I put in the link to the article about the language of diabetes, and then there's a nice chart that the diatribe posted about not calling persons with diabetes diabetic. So the red is what we're trying not to use so that we can be a positive, and the green is what we're supposed to try to use. And then here's some 10 steps that you can share with your patients, and then here's all the resources. Any questions?
All right, if anyone has any questions, please go ahead and put it in the chat or raise your hand, and we'll be glad to take a look at them.
Somebody did.
All right, Hank, just one second.
Does he need to unmute?
Hank, you are unmuted. There you go.
I did it myself. I just wanted to add something that I read in one of the financial newsletters that I receive periodically, that one of the larger side effects of this business closure due to COVID is that people are no longer working, they're no longer getting a paycheck, and it comes down to, what do I do this month? Pay the rent, eat, get my meds, and that is a real problem with a lot of people who have been cut off from their normal source of income.
Okay.
Thank you, Hank. Badrea, you are, well, just one second.
They want me to.
You should be unmuted. Go right ahead.
Sorry, was someone else talking?
No, go ahead.
I was just going to say everybody's going to have access to the slides, right, Garth?
Yeah, we'll post the slides tomorrow when we post the YouTube of this town hall, and they'll be on the COVID-19 resource page under the town halls.
Also, Maggie, if you need them sooner than later, just email me and I'll send them to you directly. This is open to everybody. I'll give you my email. Go ahead, answer.
Go ahead, Badrea.
So Starlin, hi, thank you. My question is more with regards to people actually being able to obtain extra supplies of their medications. One of the concerns that I have heard raised by pharmacists quite often is that there will be a shortage of medications, similar to what happened with hydroxychloroquine, when everyone started prescribing it and taking it. But I've also heard of difficulties in obtaining albuterol inhalers because patients with asthma were attempting to stockpile it. Have you actually seen any evidence of shortage of diabetes medications?
So one thing that we're experiencing right now is a recall of metformin, which has shifted the availability of some of the non-tainted metformin. So we've seen a little bit of that. I'd have to call on to my pharmacists that are in the real world, but I just know on the chat boxes that I've been seeing some metformin concern. We contacted, before I did I gave this talk to the state of Illinois people yesterday, and we contacted Sanofi, Lilly, and Novo Nordisk, and they did not indicate that they would be running out of anything. But those are brand name drugs that not everybody has access to because of their expense. So I'm going to open this up to, Gary or any of you that have been in regular dispensing, because we did contact the 3 main insulin providers because we had that concern.
Thank you.
And if anyone wants to add into those comments, you can please put those in the chat or raise your hand and we'll be glad to unmute you. Anyone else have any questions or comments or concerns? All right, Starlin, anything you want to add before I switch over to the CE code real quick?
I just think that you could build an awesome relationship with your people that have these chronic comorbid conditions and lock in their loyalty to your pharmacy by reaching out. I didn't spend a lot of time. You can tell from the survey that a lot of people are staying home, and so we have some social isolation, and people with chronic diseases have underlying depression. So if you have, it's summertime, so if you have a student intern for the summer, I'd love to hear the great stories about pharmacists calling and checking on their patients by phone just to see how people are. So let's be the saviors of COVID and reach out to our patient populations. And thank you again for letting me sharing more data. And thank you, Jenny.
Thank you, Starlin.
And thank you, Karamet.
First thing I want to announce before we go any further into our normal update is that today we are officially announcing, after a lot of meetings and considerations and looking at what's best for the safety of not only IPHA members, but also members of the Missouri Pharmacy Association, because this year is scheduled to be our joint meeting. We have decided not to physically hold the 2020 conference at the Hilton at the Ballpark in St. Louis. We will be holding the conference virtually. So September 24th through the 27th, 2020, which I know you all have highlighted and marked on your calendars as a weekend which you're devoting to IPHA, you will continue to do so, but we will be doing it virtually this year. And so a lot of the experience that we've gained from the feedback from a lot of you through our town halls and through some of our virtual continuing education that we've done over the last couple of months through COVID has really kind of prepared us and made us feel really strong with going forward with a virtual conference and being able to offer you the same quality experience that you have at our annual conferences, except we'll all be on our computer. And that doesn't mean it's all just going to be lectures. We'll still have discussions and updates on the association. We'll still be handing out awards. We'll still be looking at what the students are doing in their competitions. And we're also experimenting and thinking of some unique ideas to be able to make this very interactive throughout the entire experience. So I do encourage you, registration will be starting soon. We will be having that up here in the next week or so after we get everything retooled with the schedule. And but we did want you to know, once we finally were able to work everything out with the hotel, and that's what we've been delaying on the last couple of weeks, is trying to get everything finalized with the hotel and making sure that everything worked out well for everyone involved. But we do look forward to seeing you in September virtually, just like we do every week right here at our town hall meetings. So as with our town hall etiquette, again, everyone's been muting well, knowing how to raise your hand. Don't be afraid to use the chat. This is your time. We did cross that 2 million barrier of cases, as we knew we would last week, and the United States is at 2.1 million cases. The world is at 8.3, and we have seen almost 1 million people added on. No, I think it was, about 500,000 people added into the recovered category since last time that we met. So we're now at over 4 million, or half the globe has considered recovered from COVID-19, which I think that's great. And I think we need to be focusing on that great number, that 50% of the cases are considered to be recovered. And I know we focus a lot on the deaths part, and I understand that, but I still think we need to be looking at the positive as we move forward with how we're going to continue to incorporate COVID-19 into our healthcare treatment and prevention guidelines. As for Illinois, this data seems to be corrected from what was inputted up to the state earlier today. We're at 133,000 cases. We have been trending lower. If you remember, in past weeks, we've had over 1,000+ cases a day. So earlier this week, we were down as low as 473, I think was the lowest number that we've had so far in many weeks. And so Illinois is flattened the curve and is starting to trend down, and I'm hoping that continues to be that way. If most of you may have seen, especially shared on social media, the New York Times did an analysis that was published over the weekend, and it shows that Illinois has the greatest amount of decrease in COVID cases in the entire country. And I think we got to be proud of ourselves because we're part of that success. And I want to thank every one of you for being part of that. And we have to continue to work with our colleagues in other states and try to help promote them. And as we start to see increases, even in our surrounding and border states, as we go forward. And then finally, in the social media, we're still seeing that Illinois is at an F for social distancing. And again, I think this data, I'm probably going to be the last week that I'll share it. As we start to reopen, especially now that we're in phase 3, people are getting out. They're not as homebound anymore. They're starting to go out to eat at restaurants that are offering outdoor seating. And so things are starting to return to a newer phase of normal. I think it's been interesting here in Springfield, at least, noticing all the restaurants, people getting back out and trying to readjust to being out. And I think it's been a positive experience, at least here in Springfield, and we haven't seen any adverse effects of that type of gatherings as of yet, and I hope we don't. And I hope we continue to see, and I hope we see a lot of the 4 regions, as we've talked about in the reopening Illinois, that will go to phase 4 here at the end of the month. And I know there were some questions or comments that came up while I was in the share screen and I couldn't see it. So it'll look like everything's pretty good. Any questions or comments? I know that they're talking about medication shortages in the chat. We've seen famotidine. I know it's been on shortage. I would be interested to hear feedback with how dexamethasone is going this time next week, as that is now, interestingly, is now a treatment option for COVID. If you remember, and we specifically talked about it on this very town hall, that steroids were not to be considered to be used for treatment because it could actually make it worse. It's interesting how, as we continue to gather new data, start to look at medications a little bit better, that some of these are becoming valid treatment options. And if dexamethasone is, I really hope it's something that we can continue to use, especially from the economics side of treatment. It'd be nice to have a medication for active treatment that's on the more affordable side for patients, so we can make sure that it's accessible to everyone. Gary, you've got your hand up. Let me get you unmuted here. You are unmuted, sir. Go right ahead.
Am I really unmuted? Can you hear me?
You are unmuted. Go right ahead.
Just a couple things. One, following up on Shane's chat just about shortages. We haven't yet seen the metformin ER be a problem, but it is, I'm sure it's going to be a problem before we get going very far. Famotidine loosening up, albuterol still all right, but no insulin, no DM meds. I mean, everything seems to be all right so far, so we'll have to keep track of that pretty close. My question for Starlin is, how are we going to do Jeopardy remotely? And I'm willing to host a remote hospitality room, a remote hospitality suite, if there's a way we can do that. Just volunteering, just saying I'll be glad to do that if that's something we can do.
So it's interesting that you say both of those things. So Kim and all of us have been trying to figure out if we can do the Zoom rooms and do something with Jeopardy. I don't know. We thought about having people get their trivia group people together and have one representative, and then I don't know. I'm open to any suggestions, and it would be a lot of fun. We have something in mind, Gary, for another thing. We'll include you in on it since you jumped into it. So we've been thinking about having some Zoom rooms for sure.
All right, I'm in.
So, yeah, and we definitely have a couple good ideas for some virtual hospitality. So
yep.
We've got some ideas to make it a little not all about business, not all about education, but the important networking and just being around each other, even if it's just around the computer screen.
People in my treehouse for a long time.
Well, exactly, and if we got to be there virtual to start.
Well, we'll have some libations. Isn't that what Cody calls them? Adult libations or something like that?
Exactly. And I'm going to pause the recording again real quick.